you will hit your goal, you will hit your targets. And that's how we're trying to simplify things for every single chronic disease. And the data has to be accurate. You know, all of you who have worked in this room on registry, you know that when we present data to them, it better be clean, right? Because one data point is wrong, the whole thing gets thrown out. So I think there's so much work which goes in the back end to scrub this data, make sure it's clean and accurate. So let's look at, I think hypertension is one of the big things Harry wanted to stress about. So the way we are still, we still have long ways to go for hypertension management. But the way we are trying to do this is, and here's some questions for this group. So what do you think? For every 5 millimeter reduction of systolic blood pressure, it will result in? That's correct. That's 14%. The way we're trying to tell every clinician in the room when we go around is you lower it by 5 millimeters, almost 50. I just use 15%. It's easy for me to remember. 15% reduction in stroke. And when you look at annual cost for hypertension, what do you think it is? That's correct. Again, $733 per adult. So when we say, but if we do not have people under control and people go, as hypertension is the top 2 reasons for people having end-stage renal disease, requiring dialysis. As per CMS, and I have 2 CMS experts here, but I think as per CMS, what's the average annual end-stage cost for requiring dialysis? I think I messed up here. It's a 70,000 annual cost. So you can see again the cost of, it makes perfect sense that we as a group focus on blood pressure control. And it's part of now all our value-based program, all our ACO program, meaningful use programs, including in San Diego, we have the CMMI collaborative grant, where 8 healthcare systems are getting together to see how we can really lower the blood pressure, better control blood pressure for 4,000 seniors in San Diego. So this is, this has become a very important, and I'm sure I'll hear more about it on the Million Hearts. But when we look at Sharp-Estelle, we have 33,000 members diagnosed with hypertension. I'm sure we have more who we haven't found, but 33,000 members have hypertension. Again, if you do the math, 33,000 times 733, or how many dialysis you can prevent, it's a very it can be a very costly problem if we are accountable for it. So our rate right now is around 75% control. 75% of our population has blood pressure less than 140/90. 24% is above. And I think we should be able to get to, our goal is that we should get to 82%. I know that here in Northern California, you have, I heard some guys are there, but I think you have a control rate of almost 85%, I think so, in Northern California. So I'm sure that we can also try to achieve that goal. So the way we are trying to do this is using our AMGA, measure our pressure downs, the planks, the 8 planks for this thing. This is led by Dr. Jerry Penso. And here you can see the ones in orange are what we are focusing on, the guidelines. Again, these are the guidelines we have. I gave a copy to Dr. Farmazine, and if anyone needs it. And then how many patients not seen at goal and how we can bring them back, and how can we really focus on prevention, engagement, and self-management. And this is a data which, again, is showing, here is a data for people who have diabetes and hypertension, the high-risk patients. And here you can see what's what's the distribution, peer review. This is all transparent. This is all shared in the public, and you can see that one site has better control than other site. But also at each site, then we can divide show the data for 12 of the physicians. For example, at this site, there are 12 physicians practice 12 practices led by PCP. In month of March, what were their bundle diabetes? This is bundle diabetes score. The bundle diabetes, you can see on your left-hand side, the person who had the highest, but here there were 4 or 5 practices which were sort of lagging behind. So by having a good intervention, focusing on those practices, in October you can see that all the practices, some of the other practices also came up. So this was a question last time when I was here, Dr. Betsy Thompson asked me this question. I thought it was a very good question, that's why I made sure that I had this slide to show how before and after the thing. But also I think we are focusing on, we are also telling our practitioners who have not hit the goal. See, if you look at sharp distillery, if we hit the entity goal, we all are equal share. It's a very social society, everyone gets an equal share of incentive dollars. But now, if you are not getting hit, we do pay the panels, we do pay the doctors for taking care of the patient. When they see them, they do get paid. But now if they are scoring below a certain threshold, and if there are no exclusions like you're on maternity leave or something, then additional incentive dollars will not be given. So that's how we have, because we don't get paid on the value-based care, so why should we pass that on? So I think that has been a very clear direction given by the board, and I think we'll see how that goes. So, but what happens for hypertension is many times people tell me, that look, Parag, I can't really change anything, because my patients have resistant hypertension, which means that they have been uncontrolled blood pressure in the office, they're on 3 or more drugs, including diuretic. So what do you think? How many will eventually become normotensive with the help of ambulatory blood pressure monitoring? And this is my last question, so I hope you can vote, because I've been seeing as people. First I started with 60 and it's not. 2 more. It's 48. Okay, that's fine. So I think the answer here is that almost 30%. 30% of people will eventually become normotensive ambulatory blood pressure monitoring. In fact, if you request your patients to do tracking of their own blood pressure at home, or we track for them, they have 4 times higher chances of being in control and being adherent to their medication if you don't compare to people who are not. So this was a very well published Spanish study which showed the data. So the way we are trying to target our high-risk hypertensive patient is that if people have blood pressure not in control, and then we're using their high risk, I think we're using now more the atherosclerotic cardiovascular disease risk score, the ASCVD, and you can Google and find it. And here, if they have a high blood pressure, then we are sending them with a wireless blood pressure cuff. Some of the patients do get that. And then we are monitoring with population health nurse. We have a health coach who is, really talking to patients about health literacy, at that level, and trying to address those issues. We have a pharmacist as part of the team, and if patient has more than 3 antihypertensive medication, that's being reviewed, making sure that people are taking the ACE on thiazide diuretic, and then demonstrating control back to primary care physician. And we hope that by doing so, we can really drive the performance up towards 80% and higher. But also we are partnering with community, the same as we have as part of the San Diego's Be There campaign, which Hattie was the first one to start in San Diego. But there's a whole campaign now, marketing campaign, to make sure that San Diego is heart attack and stroke-free zone. And then, so based on that, if you look at commercial managed care population, yes, Sharp Distillery has, about 90th percentile in California. It's about the high, when you look at AMGs, measure of pressure down, campaign and national testing, yes, it's on the highest quartile, but I don't think we are there yet. I think we still have to get higher, we have to get to about 80%, and that's a journey we have taken on, and we hope that we can soon hit our goals. So, but for diabetes, again, I think the diabetes bundle care, the way we have changed the bundle care for us is that patients have to have A1C less than 8. They have 2 A1Cs per calendar year, LDL less than 100. Because LDL measure was dropped from many of the programs, are they on a statin, especially a high-dose statin. And blood pressure is less than 140/90. Based on that, you can see that 54% of patients have a perfect care for diabetes at the group level, which again is in the high, in the California level is pretty, and national level is pretty high, pretty good rate. But I think the thing which excites us more is that are we really making a difference in the lives of the patient? Are we really reducing the complication? And this is just a preliminary data here. We can show the green is all the people who had a perfect control of diabetes for some time. Red is people who did not have control for diabetes. Even one thing missing for one time, even if your everything was under control, blood pressure, everything, but if your LDL was just 101, you would get into the red bucket. And now you can see what's the relative risk reduction for MI, dialysis, retinopathy, and stroke, and you can then calculate your cost avoidance. This is the cost avoidance, not the internal cost, the total cost avoidance. And that's how we can demonstrate a reduction in complications, and we can demonstrate a reduction, we can demonstrate an ROI in all the programs which we had. And similarly, we tried, here on your right, on your left-hand side is the CAD hospitalization for the group members. You can see it has gone down. But for stroke, it hasn't. It did go down a little bit, but not as much as we would like to. And that's why I think we are focusing on the blood pressure program as you are, to really make a difference, to really bring it down further. But when we look at population health, one thing to remember is it's not, unlike an ER physician, right? In ER, you take care of one patient, you do CPR, you save life, anecdotally you're the hero, right? But in population health, it takes a long time. We need 86 more patients to be under control to reduce 1 MI. For stroke, we need 63 more patients to be under control to reduce 1 stroke. So if I have 120 patients, right now in the program, we might be able to reduce 2 stroke. But we have to get more and more a larger group of patients. So I hope over time, that's why we call it 2020, it takes time to really get to those results. And this is the collaboration. Again, I think such collaboration helps to motivate people. I think we have, I think those of you who have visited San Diego have a similar collaborative. It's at a beautiful location, and you can see here, you can come and learn. And also, if you have time, you can go out on the pier and you take a walk to the pier. The only thing is that we do not ask is for a glass of water. San Diego has severe drought happening. But this is a wonderful team who does the work. My job is to take their photographs. But I think these are all the clinicians who have really driven the culture towards really improving the health of the population. But the lessons learned, just to wrap up everything, these are on your left-hand side are all the registry and all those things. But when you look at registry, let's make sure that we have a common electronic health record and it's peer reviewed. When we look at physician engagement, let's keep it simple and centralized. When we look at team-based healthcare, we have to see who's on our team and are they co-located. When we look at patient engagement, we have to make sure we are measuring effectiveness and health coaching. And when we look at medication bundle, let's see if we can use cost-effective ACE and diuretic as the first line. For telehealth, let's only deploy it for people who have high-risk hypertension. And change is hard. Change is hard, but such kind of collaboratives really help to drive that change and the outcomes we are hoping for. And I hope that I was able to touch, give you really boots on the ground perspective. I hope I met that, objective of this thing. But the process, people, and technology, all three integrate and they work together. We cannot separate one from another. So I think just to drive home that point, and my time is almost up, but I just want to share one more clip with you, this last clip. And so that people, process, and technology all work together. So what do you think? You can't take one thing out of another. So again, for things you're going to remember on Tuesday, here it is.
Sag mal, Papa, habe ich dich noch gar nicht gefragt. Wie kommst du eigentlich mit dem neuen iPad zurecht, was wir dir zum Geburtstag geschenkt haben?
Gut.
Mit den ganzen Apps kommst du klar?
Was denn für Apps? Geh mal bitte nicht zur Seite.
So with that, I welcome your questions, and if you have any hard-hitting questions, that's also welcome. But I think your time, shall I wait for later on for questions? Or?
Well, I think that we could take a couple questions now, and I'm going to kick it off by saying that I love what you're doing with team-based care and hypertension control, and I wonder if you could talk about the warm handoff. Say, one of the barriers we've seen in our pilot project so far is if the physician does not recommend to the patient, I want you to work with this pharmacist to titrate, or I want you to work with this other care team member, it doesn't usually get traction.
Yeah, I think you're absolutely right that if a physician or NP and PA, all the clinicians involved, if they don't recommend the care team member or they do not manage up the patient, I think the uptake will be very poor. I agree with that. But I think at the group level it takes time to really, I think it's a cultural thing. I think at the group level, a lot more clinicians now are very used to having teams as part of it. In fact, if you pull out, for some reason, if we have somebody like a diabetes disease manager, not at the clinic side, I get phone calls to say, when is this person coming back? So I think the team, it's a cultural shift. I think people have to trust the nurse. The first time is the trust. You have to just say, just trust them with one patient, and you have to make sure that you do a really good job. And then, then the other cases, start coming your way. But I think it, I think there's a famous quote from the Twitter guy that it took me 10 years to become an overnight success. So I think in a way, it's a cultural thing which physicians do participate.
Parag, I have a question that's following from the team-based care. As you use social media and portals and your health coaches, is the team concept expanding into the community? I mean, the physical activity, I think you were starting to allude to the community partnership, but when you say go out and exercise, which is kind of where it usually ended 10 years ago, now probably your folks, because you compared, for instance, geography, East and West County, different resources available for things.
So again, I think that's good. The first thing is, if you think about healthcare, we call ourselves healthcare delivery system, but our focus has been on sickness care. So what are our boundaries? Where do we say that this is part of my sharp medical group's responsibility, and this is part of your public health job, right? But I think we are seeing that boundaries blur a little bit more, and if we are accountable for the cost, and if we are accountable for the measures, I think we are trying to deploy more resources out in the community with, so I think we have this whole healthier coaching program where we do bring people into one center. But I think, like I said, traffic is the biggest challenge in San Diego. We are looking at online ways. We do community screenings at the mall, and the shopping, and the school. So there is a whole community outreach. The best thing which we can do and which we are trying to do is to really focus on our own employees, Sharp has the largest, one of the largest employers in San Diego. It has 17,000 employees after the military, I think. So I think, if we can improve the health of our own community first, our own employees first, I think then we can continue to extend it.
Thank you.
So with that, thank you very much for your time and attention. And if my email is here anytime, you can feel free to send me an email. Thank you.
Now we're going to hear from Dr. Betsy Thompson with the Million Hearts Update, which I'm sure you're all anxious to hear about what the federal government is doing nationally with these same issues.
Well, the slide I really want to have for you, I keep wanting to have, I still don't have, which is where are we exactly with the Million Hearts goals? But there's still a few things I wanted to talk to you about just in terms of an update and kind of what I've been up to currently. So a couple of people have asked, what do we do in the Office of the Assistant Secretary for Health? And it's sort of more a question of what don't we do. This is a list of some of our key initiatives, and I put Million Hearts up there at the top since that's the context for today. But the Office of the Assistant Secretary for Health is in the Office of the Secretary, and we deal with a lot of the different cross-cutting interdepartmental initiatives that the federal government is involved in related to public health, Million Hearts being a prominent one. And on that note, we do meet interdepartmentally every other week around the Million Hearts. So there's a lot of work going on. The fact that I don't have that slide that I want to give you doesn't mean that we aren't busy talking and strategizing about how to continue to get energy and momentum with the Million Hearts initiative. I don't need to tell this group what the goal is in terms of preventing 1 million heart attacks and strokes. You're all so engaged in this already. It's always wonderful to hear what folks are up to, and to get the update from Parag is really nice to hear. One thing I do focus on when I show this slide, again, you all are very familiar with the top part of this. I think sometimes there's less emphasis and less attention given to the very last bullet on this. And in fact, that heart disease and stroke is the leading cause of racial disparities when it comes to mortality in this country. So it's a huge issue for us in the department since we are very focused on reducing and eliminating disparities in health. These are the targets that were set, and this is the slide I very much want to have that other column in, which is where are we today. But the pre-initiative estimates, I wanted to just draw your attention to that blood pressure control, where prior to the start of the Million Hearts, it was less than half of those individuals with hypertension were controlled at the onset. And I was looking at the data that Hattie gave us today. Now this is only through 2012, but in California health plans, you're now averaging, as of through 2012, 69%, and we've heard from Sharp where they are now up, 75, closing in on that goal of above 80. So we are making progress on these. Smoking cessation, this is about smoking cessation advice, but I also want to give you a little pat on the back because we continue to make progress in the country and in California on smoking cessation. The last numbers from the National Health Interview Survey, they kind of do a rolling, I think it's about quarterly, it might actually be four months that they look at. We're down to 17.1% current smokers in the country, and in California, based on the behavioral risk factor surveillance system, you're down to about 12.5% of adults being current smokers. So we're certainly making progress with traditional tobacco. I don't even want to talk about e-cigarettes and what's going on there. Not quite as rosy of a picture. But I think there is a lot of progress going on across the country because of efforts like Sharp's and many of you in the room and what you've done. Another thing I wanted to just make sure you're aware of, the interactive atlas that's shown here of heart disease and stroke has been available on CDC's website for a while, but it was recently updated. I can't see this, I'm pretty sure you can't see it, but what I have pulled up here, you can go in and you can say what state you want to look at, and then you can pick all heart disease or coronary heart disease, acute MI, heart failure, hypertension, etc., and look at things like the death rate and hospitalization, hospital discharge data by county level. So it's just an interesting resource and might be useful for some of you if you're not familiar with it. And I've given you the website on this on this slide. I feel like I'm preaching to the choir here, but I did want to go over some of the action steps that, for depending on your kind of sector. And the neat thing about this group is you have pretty much every sector in this room. So I know we have a couple of the local health folks here from Sacramento, and I really congratulate particularly the local health departments when they're working on the last two here. There's a lot that can be done only at the policy level in terms of both the foods we eat, but also the air that we breathe, and keeping those of us who don't use tobacco free, and helping others become that way. Healthcare systems, we have several of you in here, and I can't top what Parag talked about in terms of what you can do to achieve excellence, not just with the B in the ABCs, but throughout. I'm sure that Sharp could achieve just as significant, or may have achieved just as significant sort of milestones in the other parts of the ABCs as they have in blood pressure control. Clinicians, there's just so much to do. And one question I didn't get to ask Parag, but that I always think about, whether we're talking about physicians or pharmacists or any other type of clinician, is, it's easy to talk about patient engagement. It's easy to talk about medication adherence. It's very hard to get clinicians to be able to do that in the most effective manner. Most of us weren't trained to do so. It doesn't necessarily come naturally to us, although it can in fact be learned. And it's been shown over and over again that you can teach, whether it's a pharmacist, a physician, a nurse practitioner, a nurse, or anyone else, they can be taught to do much better in terms of how to engage patients and how to improve the medication adherence that's so important. I kind of lump pharmacists in with physicians there just because it is all about the clinical system, I think, and the team that we've heard about today. And then finally, the payers. Well, there's still a lot of work that can be done. I've been in this world. I argued, not daily, but at least weekly with the CEO to reduce all co-pays for chronic maintenance medications. I never won that battle before I left, although it has since happened in a number of HMOs, not just the one with payers, not just the one I was with. But we do need the payers, not just in this room, but the payers that are in our world to be on board with this, because those structural the structural incentives really do make a huge difference in our ability to achieve what we need to in this arena with Million Hearts. And very akin to that is that the role that employers can play. And we see this a lot in California. We see some very activist employers. We also see many, many that are sitting on the sidelines. I did want to mention the 2014 Million Hearts Hypertension Control Champions. 2013 was the first year that this was done, and there were just a handful of champions. Kaiser Northern California was one of them. To be a champion, you have to, among other things, have more than 70% or more of your hypertensives under control. So in 2014, we had 2 of the 30 nationally were in California. One was Family Health Centers of San Diego. The other was Kaiser Southern California, and I fully expect Sharp to be on there next year, right? So actually, they meet the basic criteria they meet now. So I'm not quite sure how that happened, but they weren't on there this year. But this is just one more way. You all do your platinum champions and other levels of recognition. It does matter, so we try to recognize those that are really leaders in this field as well. That's all I have for you today. I'm happy to answer a couple of questions if you have any. And like I said, it's really great to be here with you again. Thank you. Are there any questions? If not, I will turn it back to Hattie. Are you closing up or?
Well, we want to have a conversation with the folks in the room
Okay.
about what can be done in the area. So, for instance, Dr. Agnihotri was talking about the great results he's seeing with using the home blood pressure monitors. And I'm wondering, how do you get the patients to use them? Do you cover them? Do you give them free?
No, I think, so they're free. So any kind of monitoring device we give patients are free. So they're all free, and I think it depends on what's the connection first the patient has with their team member, whether it's disease manager or case manager. So I think that's important. I'll give you an example. We tried one time a pilot with for asthma sensors, and we just called 50 people and say, hey, we have a free sensor. We want to track how your asthma is. Do you want it? And I think almost 40 people said yes. And within 1 week, we had shipped 40 sensors to people's home. Right? So I was so excited. I said, wow, that's great. In 1 week, I have 40 patients. Turns out after 1 month, we found that 20 people had not even opened their boxes, and 5 people were using the sensor. So I think the lesson learned was that we cannot just send it to them. We have to engage them first in their own ongoing, and then say, look, this is a tool which will help me take better care of you at home. And that crucial conversation has to happen first, and then we send it.
So you do that in the office?
Which, I think in office or by home, first we have to have a connection. We may ship the sense, like for example, the scale directly to people's home, but we have to first have that kind of commitment to a self-management.
So are others in the room using self-monitoring devices? Joan, could you talk about that?
I just wanted to make a comment. I mean, we've been using monitoring devices for diabetes for years, and patients would get the monitor, go home with it if it was given out, because a lot of the companies initially gave us free ones to distribute. Oh, I'm sorry. And when we would send the monitors home, if it was just given to the patient in a box, yeah, they could figure out. But when there wasn't that engagement, if no one asked them what their blood sugar was, or there was no inquiry or interest from the care provider, they went on a shelf. They didn't use them either. So, it's the cost can be prohibitive, but nowadays we know there are ways of getting around that. But it's that interaction has to take place, because why bother sticking your finger or taking your blood pressure if no one cares but you, and you don't know what to do with it? So I think it's the interaction.
I have 2 questions. One, when you give out this blood pressure monitors, do you also ask them to bring it in to calibrate it? Because the measure may not be the same, and they may not be doing it correctly, number one. So that's one question. The second question I have is on the clinical guidelines that your committee have implemented in your group. How is it actually being used? Is it posted